ตอนนี้มันเห็นโอเคไหมคะทุกคน ขอถามแบบ
เปลี่ยนสไลด์นะคะอาจารย์
โอเค เราจะใช้วิธีการเขียนไปด้วย ขอโทษที เราอยากเขียนย่อหน่อย So the first topic is echocardiography assessment of pulmonary hypertension. Firstly, you have to know about definition of pulmonary hypertension, and from European societies of echocardiography. The definitions of pulmonary hypertension is defined as increase in mean pulmonary artery pressure, which is equal to or more than 25 millimeters of mercury acid. And is what assessed in lying position and is what assessed by right hand catheterization. Because right hand catheterization is directly measurement in patient heart, and these definitions of pulmonary hypertension is based on invasive measurement. So right hand catheterization is the gold standard for assessing pulmonary hemodynamic. And for normal mean pulmonary artery pressure is 14 millimeter of mercury, and for patients who have mean pulmonary artery pressure 21 to 24, this should be carefully followed. And this recommendation from the SIGPO Symposium on Pulmonary Hypertension, or WSPH, in 2018. Pulmonary hypertension is defined as mean pulmonary artery pressure greater than 20 millimeter of mercury acid and in a lying position, with mean pulmonary artery pressure between 21 to 24 millimeter of mercury is considered high risk patient with a poor outcome. And WSPS recommended to identify capillary pulmonary hypertension. PVR should be included in the definition. So you see PR here. And this is classifications of pulmonary hypertension. WHO classification of pulmonary hypertension categorize clinical condition into 5 groups. According to right clinical presentation, pathology, hemodynamic condition, and treatment. And group one is pulmonary arterial hypertension. The major pathology in this group is obstructions of pulmonary vessel. These are example cause. So this cause decrease in inner diameter of pulmonary capillary that at the end is lead to increased pulmonary vascular resistance and result in high pulmonary artery pressure. Group 2, pulmonary hypertension due to left heart disease. Example cause are valvular heart disease, systolic dysfunction, diastolic dysfunction, congenital heart disease, cardiomyopathy, and so on. And you have to know that pulmonary hypertension due to left heart disease is the most common form of pulmonary hypertension, which assessed by echocardiography. Group 3, pulmonary hypertension due to lung disease. The most common lung disease usually associated with COPD, interstitial lung disease. Group 4, pulmonary hypertension due to chronic thrombotic pulmonary hypertension, or is also called CTEP. In patients with CTEP, they usually have thrombi attached to pulmonary vessel. So it may occluded lumen and lead to increase in pulmonary pressure. Group 5, pulmonary hypertension with unclear mechanism. Example cause are chronic renal failure and lung tumor. Pulmonary hypertension can be defined by using pulmonary artery weight pressure into two groups, which is pre-capillary pulmonary hypertension and post-capillary pulmonary hypertension. The term pre-capillary pulmonary hypertension is a disease which affects pulmonary artery and lead to pulmonary vascular obstruction. Hemodynamic definition of pre-capillary pulmonary hypertension are increase in mean pulmonary artery pressure and normal weight pressure, and PVR is more than 3 Wood unit. For post-capillary pulmonary hypertension is a disease which affect increase in LAP, and this backward to pulmonary vein and pulmonary capillary, and this to increase in mean pulmonary artery pressure. And post-capillary pulmonary hypertension, hemodynamic definition include increasing mean pulmonary artery pressure, increase pulmonary artery weight pressure. And this group post-capillary pulmonary hypertension include group 2 and group 5. And according to the 6 WSPH, they recommend that PVR should be included in the definition of pre-capillary pulmonary hypertension, right? As I mentioned previously. So a PVR cutoff value 3 and more is defined as pre-capillary pulmonary hypertension. But in patient with clinical group 2 and group 5, if PVR is more than 3, that means patient with clinical group 2 and group 5 are called combined pre and post capillary pulmonary hypertension. Okay, เจ๋งมากเลย This slide show systemic sclerosis, it is one cause of connective tissue disease, and this is example cause of group 1 of pulmonary hypertension. Patients usually have thickened skin. When you see a patient with systemic sclerosis who was referred to echocardiography, don't forget to assess the probability of pulmonary hypertension. Okay. This diagram show hemodynamic of pulmonary hypertension. Show hemodynamic of pulmonary hypertension due to pulmonary arterial hypertension, lung disease, or patient with CTEP. In summary, patient with the lung disease, as I mentioned previously, they have high PVR and increase in mean pulmonary artery pressure, but LAP and LVDP should be normal. In this table show let you think about a patient with lung disease or COPD. The patient usually have poor acoustic window because they have a problem with their lung and it's filled with air. Even patient have poor acoustic window or echo is not reliable for assessment of pulmonary hypertension, but echo is still recommend as class 1. For patient who suspected pulmonary hypertension with lung disease, and echo is not used for not only used for the diagnosis, but is also used to assess cardiac change and used to assess echocardiographic sign of pulmonary hypertension. Group 2 of pulmonary hypertension. Group 2 is pulmonary hypertension due to left heart disease. Left heart disease is the most common cause of pulmonary hypertension. And left heart disease is conclude pre-etiology, which LV dysfunction, LV diastolic dysfunction, and valvular heart disease, MSMRASAR, or combined valvular heart disease. And this diagram show normal hemodynamic, and this diagram on your right side show hemodynamic and pathology in patient with LV dysfunction, which include reduced LVEF and include preserved LVEF. This can cause increase in LVEDP, LAP, and result in increase in mean pulmonary artery pressure. In patient with mitral stenosis, this diagram show there is obstruction of blood flow at the level of mitral valve, and this leads to increase in LA pressure. LA is enlarged, and then pressure is backward to pulmonary vein and leads to increase in mean pulmonary artery pressure. And in long-standing of MS, PVR may increase. And In patient with mitral stenosis, TR, tricuspid regurgitation, is usually present because of RV dilatation and RA dilatation, which is consequent of pulmonary hypertension. So patient with mitral stenosis, they may have isolated pre-capillary pulmonary hypertension or combined pre and post-capillary pulmonary hypertension. Sorry. Okay, and this diagram is present about patient with mitral regurgitation, which blood flow remain in LA and LV, and this lead to increase in LV-EDP, increase in LAP, and in patient with chronic severe AR, LV volume lead to LV dilatation. You see LV dilatation and LV diastolic dysfunction, and at the end LA enlargement is present. And so you could see LV dilatation and LV enlargement in patient with mitral regurgitation, but you couldn't see LV dilatation in patient with mitral stenosis. If LV dilatation present in patient with mitral stenosis, that means the patient may have other etiology, such as coronary artery, or MS with MR, or MS with OR, with AR. Okay. LV, don't know. If you see LV dilatation, you should find other cause of LV dilatation in patient with mitral stenosis. Okay. Next diagram. This is diagram present about hemodynamic in patient with aortic stenosis. In this patient, aortic valve cannot open fully, which block blood from blood flow from LV to AO and to your body. So the obstruction lead to increase in LV systolic pressure and lead to LV diastolic dysfunction, then LV EDP increase. After that, pressure is back into LAP, pressure increase. And also mean pulmonary artery pressure increase. And a diagram on your right side present hemodynamic and pathology in patient with aortic regurgitation. That is blood flow back to LV during diastole, so LV EDP is increased. Is increased rapidly. In patient with chronic AR, this lead to LV dilatation and LA enlargement is present. Next, LAP pressure increase and mean pulmonary artery pressure increase. This show cardiac change, secondary to pulmonary hypertension with pressure overload. Cardiac change it depends on overload severity and rapid onset of the disease. So we has sensitivity to afterload in response to pressure overload. Are we myocardial hypertrophy occur? And renin-angiotensin system leads to RV myocardial ischemia, and at the end, RV dilatation occur. With chronic pressure overload, RA pressure increase. And RV dilatation and is lead to RV failure. And you may see functional tricuspid regurgitation in patient with pulmonary hypertension, and functional TR caused by RV dilatation and RA dilatation. This echocardiogram of normal patient compared with patient with pulmonary hypertension. A is normal parasonal long axis, and B is parasonal long axis in patient with pulmonary hypertension. You will see dilated RV with RV wall hypertrophy. D is normal parasonal short axis of mean pulmonary artery level, and D is a parasonal short axis in pulmonary hypertension, which show dilated mean pulmonary artery. E is normal umbilical flow chamber wheel. Did you remember RV is RV is less than 1/3 of LV. This in normal case. And F is apical flow chamber wheel in pulmonary hypertension, and showing RV dilatation and RA enlargement. And this slide show a typical symptom of pulmonary hypertension, which are tonic of breath, fatigue, weakness, angina, presyncope, and syncope. And for physical examination, you may see elevated JVP, hepatomegaly, peripheral edema, or you will hear systolic murmur of tricuspid regurgitation and diastolic murmur of PR, dias. And this table, and this is the table of diagnostic strategy in pulmonary hypertension. You see pulmonary echocardiography should be performed in patients who suspected pulmonary hypertension, and it recommended at first line. And the assessment of pulmonary hypertension should be routinely used in patients who undergo for echocardiography. And this table shows the recommendations for right heart catheterization in patients who suspected pulmonary hypertension. Right heart cath is recommended in class 1 to confirm diagnosis of pulmonary hypertension, pulmonary arterial hypertension, and recommend to perform in expert center. Recommend in patient with congenital shunt and recommend in patient with pulmonary hypertension due to left heart disease or lung disease, as well as in patient with CTEP. And echo is recommend, right heart cath is recommend to confirm the diagnosis and to support treatment decision. And as I mentioned previously, pulmonary hypertension assessment should be routinely used in all patients who undergo for echocardiography. So echocardiogram show high probability of pulmonary hypertension. The patient should go for right heart catheterization to confirm the diagnosis of pulmonary hypertension. And this is show how to assess pulmonary hypertension in echocardiography, which are recommended from ESC guideline. And this table is echocardiographic sign of pulmonary hypertension that I will tell you later about echocardiographic sign. Next, we will move to echocardiographic assessment of pulmonary hypertension. As you know, echocardiography is a screening test for patients with suspected pulmonary hypertension. It can provide information about cause, consequence of pulmonary hypertension, and echocardiographic sign of pulmonary hypertension. And it can estimate mean pulmonary artery pressure, pulmonary artery systolic pressure, pulmonary diastolic pressure, RAP, and PVR. And this method is conventional method which some center may use to assess pulmonary hypertension. So you have to know about this. Estimation of right atrial pressure. Right atrial pressure is estimated from Ivc diameter and Ivc variation with respiration from subcausal window. Diameter of Ivc should be measured at 1 to 2 centimeter from the junction with right atrium. And for accuracy, this measurement should be made perpendicular to Ivc. This is minimum diameter of Ivc in response to inspiration. And maximum Ivc diameter with expiration. Ivc collapsibility is calculated from this formula. So value of right atrial pressure Ivc diameter is normal with Ivc collapsibility more than 50. It suggests normal RAP, which is 3 millimeter of mercury. If Ivc dilate, if Ivc dilate with reduced Ivc collapsibility, suggest high pulmonary high right atrial pressure is about 15 millimeter of mercury. This AC guideline recommended by AC guideline. And this example of estimation of right atrial pressure. This is a cardiographic sign of elevated right atrial pressure. Conclude laxitic feeling, which tricuspid E by E palm E by A ratio is more than 2.1 with deceleration time less than 120. Tricuspid E by E palm more than 6, and diastolic flow predominant in hepatic vein. If you see this side, does mean patient have high right atrial pressure. In patient with elevated right atrial pressure, S wave is less than D wave, so it's decreased in systolic filling fraction, which indicate elevated right atrial pressure. If you see this slide, that means patient have high right atrial pressure. And this slide show limitation of right atrial estimation. In many patients, Ivc dimension cannot be obtained, and the accuracy between echo estimation of right atrial pressure and invasive measure is low. Next is measurement of pulmonary artery systolic pressure. Pulmonary artery systolic pressure derived from Bernoulli equation, which is delta P is equal to 4 multiplied by V square. When pulmonary valve open, pulmonary artery systolic pressure is equal to RVSP. It is like when you open a door, the pressure between the pressure difference across two rooms is equal. So PASP is equal to RVSP in absence of pulmonary stenosis or upper tract obstruction. And RVSP is obtained from RVRA systolic pressure difference, which is TR depth or TR velocity, and add to RAP. So you will get RVSP. So that PASP is equal to 4 multiplied by V square. plus RAP. When pulmonary stenosis is present, you will get Dopplers of PS like this, and after that measure peak pressure gradient of PS is subtract from estimated RVSP, then you will get PASP. And this is calculations of PSP. PSP. To assess PSP, firstly we have to measure cosmic regurgitation of max velocity from acoustic window. For example, for chamber view, parasternal short axis of aortic wall level, or modify for chamber view or subcostal window, and then use the highest one to calculate PSP. Second, you have to measure, or you have to estimate right atrial pressure. Let's calculate PSP from the following data. This patient has peak TR velocity of 4.57, and so pressure gradient between right atrial and right ventricle and right atrial chamber is so pressure gradient between right ventricle and right atrial is
81.
81 or 84?
84.
84.
83.5.
Pressure gradient นะอยู่นี่นะ estimated right atrial pressure of right atrial pressure is estimated from Ivc max 2.2 minus 1.9, and then divided by 2.2, and after that multiplied by 100. So estimated right atrial pressure is collapsibility, Ivc collapsibility. Ivc collapsibility less than 50. So estimated right atrial pressure is what's about PSP?งงไหมอ่ะ
อาจารย์คะคือได้ 13% แล้วมันปัดเป็น 15 แล้วค่ะไม่เป็น 15 แล้วค่ะ
13% มันเป็นเดี๋ยวนะ มันได้เท่าไหร่ มันได้กี่เปอร์เซ็นต์อะใช่ถึง 13 ป่ะ
หนูได้ 13.6 อะค่ะ เกิน 13 นิดนึง
IVC 13%. You go back to this slide. IVC collapsibility less than 50. Estimated right atrial pressure is 15. ถูกไหมถูกปะ so estimated PSP is ถูกไหมอ่ะถูกดิ
อีกรอบได้ไหมค่ะอาจารย์
to calculate PASP first we have to measure TR max velocity measures this TR envelope right and you have to measure peak TR peak TR velocity is 4.5 4.57 so pressure gradient between RV and RA is 84 okay. This calculated from binary equation. And second, you have to estimate right atrial pressure, which estimates from IVC side and collapsibility. So estimated RAP is 15 because IVC collapsibility is greater than 50 and Ivc diameter is more than 2.1. So estimated RAP is 80 plus 15 is equal to 97 millimeter of mercury. มีใครยังงงอยู่ไหมจ๊ะ
อาจารย์คะ
ค่ะ
อาจารย์เขียนว่า84บวก15เท่ากับ97
เจ้าเขียนถูกปะ
มันต้องเป็น84บวก13เท่ากับ97หรือเปล่าหรือไม่งั้นมันก็ต้องเป็น
99ใช่ไหม อันนี้ก็เป็น IVCใช่ อะไร and max velocity is more than 2.8 or 2.9 it indicate elevated RVSP and RVSP more than 36 millimeter is also indicate RVSP indicate elevated RVSP and y axis Y-axis is PASP, which assessed by right hand catheterization, and X-axis is PASP was assessed by echocardiography, and this study show this method. I mean PSP by echo is had highly accurate compared with invasive measurement. And this is limitation of this method. Measurement of peak TR velocity can result in overestimation and underestimation if the quality of the signal is poor. And it can result in overestimation when artifact is present, and overestimation due to overgain setting. The absence of TR velocity does not reliably echo pulmonary hypertension. And this is example of overgain setting. 4-6 now. And this overgain. This slide show severe tricuspid regurgitation because you see tricuspid valve is non-coaptation of tricuspid valve is indicate severe TR. And TR velocity can result in underestimation because there is no difference between right atrial pressure and RSP. So this patient should go for right hand catheterization for assessment of pulmonary hypertension. And this slide show this core V-wave cut off side. Which indicates severe TR. So if you see V-wave cuts off side, you can conclude that the patient have severe tricuspid regurgitation. Next, this is how to calculate PASP in patient ventricular septal defect or VSD. And this patient there is a defect on interventricular septum, right? So this is LVOT Lucy aortic valve here, and this is the interventricular septum. This interventricular septum. And this is defect VSD. And this is VSD flow across interventricular septum. A patient with VSD blood pressure, for example, blood pressure 120/80. 120 is aortic aortic systolic pressure, right? So aortic systolic pressure is equal to LV systolic pressure when aortic valve opens. So you got LVSP 120. And you want to know pulmonary artery systolic pressure. If you know blood flow velocity across the defect, you can calculate to pressure gradient. This figure to show blood velocity across VSD, which measured by CW Doppler. So you got a peak VSD velocity. You also got you also got a peak VSD pressure gradient. Yeah. So you got PASP. Right? Right. ทุกคน ฮัลโหล ฮัลโหล
ฮัลโหลได้ยินค่ะ
เดี๋ยวนะ ทำไมหน้าจอเราดับเว้ย
ตอนนี้สไลด์ค้างอยู่ที่หน้า33นะคะอาจารย์
อาจารย์
อา
คะ
จารย์ไม่ได้เปิดไมค์หรือเปล่าคะ
ฮัลโหล ก็ว่าทำไมได้ยินไหมคะ ได้ยินไหม
ตอนนี้ได้ยินแล้วค่ะ
โอเค
เมื่อกี้ไม่ได้ยินเลยค่ะ
ว่าทำไมทุกคนเงียบแสดงว่าน่าจะตอบเนี่ย เราเงียบกันจนเป็นปกติแล้วก็คิดว่า โอเค เอาใหม่ โอเค to summarize RVSP is equal to LVSP minus peak VSD pressure gradient, which is 140, and LVSP is equal to systolic blood pressure. Then you will get RVSP, but I assume 120, and it's less than 140. Actually, it should more than VSD pressure gradient, because this is this is left to right ชั้น flow อันนี้เข้าใจนะคะ เข้าใจนะ มันแค่ตัวเลขเยอะไปหน่อย In patient with PS patent ductal arteriosus or PDA, PASP and PADP can be estimated by CW Doppler cursor through the PDA flow. CW. So you will get PDA flow velocity, right? And blood pressure is 180, so you can calculate PASP from systolic blood pressure minus PADP systolic pressure gradient. So PASP is 120 minus PDA systolic velocity, which is 107, right? PADP is equal to diastolic blood pressure minus PADP diastolic pressure gradient. So PADP is 80 minus 40. So PASP and PADP can estimated directly from PDA flow. Next is non-invasive estimation of PADP, pulmonary artery diastolic pressure. This is characteristic of PR velocity. It is rapid rise in velocity in early diastole and gradual deceleration until the end of velocity or until the pulmonary valve opening. So PR velocity reflect PA to RV diastolic pressure difference. So PADP can calculated from this formula, which is equal to PRN, the absolute velocity is square and multiplied by 4 and then plus RAP. Use PRN to calculate PADP. And these are methods of calculating mean pulmonary artery pressure by Doppler echocardiography. You see, most of mean pulmonary artery pressure was calculated by using PASP, which are estimated from TR velocity. This method used when TR velocity TR6 now is well presented. So mean pulmonary artery pressure is calculated from mean RVRA pressure gradient and then plus RAP. And this area represent mean RVRA pressure gradient. So mean RARV pressure gradient is measured by tracing TR6 now. Or also called TRVTI. Next, measurement of mean pulmonary artery pressure is estimated by Mahan equation. MPA pressure is estimated by using RVOT acceleration. Which measured by PW Doppler at RVOT from paroxysmal short axis. This pulmonary valve and MPA. PW is placing here. Is placed here. Then you will get acceleration time. Acceleration time is measured from the beginnings of RVOT velocity to peak velocity.เข้าใจ And mean pulmonary artery pressure is also estimated by using PR peak velocity. PR peak velocity is here. Next is it's me called a standard method to assess mean pulmonary artery pressure, and this method depend on PASP estimation and PADP estimation. So This method had a high error rate when compared with right heart catheterization because it takes 2 times of RAP. The last one of mean pulmonary artery pressure is the Kemla formula. Is also calculated from Pasp, which calculated from TR velocity by using this equation. And do not confuse about peak PR velocity and peak end-diastolic velocity. Peak PR velocity can estimate mean pulmonary artery pressure, whereas in diastolic PR velocity can estimate PADP. ไม่งงนะจ๊ะไปแล้วนะจ๊ะเดี๋ยวเอาไปเอาข้อสอบ This is pulmonary vascular resistance. Pulmonary vascular. Sorry for my. Pulmonary vascular resistance. It is held to differentiate pulmonary hypertension due to high pulmonary flow, which may seen in anemia, hyperthyroidism, and obesity. From pulmonary hypertension, which seen in pulmonary arterial hypertension. And normal invasive measure PVR is less than 1.5 Wood unit. And PVR may be estimated by dividing TR velocity by RVOT VTI. According to error and limitation of estimation of RAP, mean pulmonary artery pressure, PSP, and PADP between non-invasive and invasive measurement, to avoid this error, echo should give information of the probability of pulmonary hypertension rather than provide definitely diagnosis of pulmonary hypertension. And according to European guideline, which recommend for all clinical group of pulmonary hypertension, the first step to measure TR velocity and probability of pulmonary hypertension is likely pulmonary hypertension when TR max velocity is more than 3.4 meter per second, and possible pulmonary hypertension when TR is less than 3.4. Finally, the probability of pulmonary hypertension can grade into low, intermediate, and high probability of pulmonary hypertension. If peak TR velocity is a good quality signal like this, and is greater than 3.4, then echocardiographic probability of pulmonary hypertension is high, and no need other echocardiographic sign. You can conclude that the patient have high probability of pulmonary hypertension. If TR velocity is below 3.4, you have to find other echocardiographic sign of pulmonary hypertension, which I will describe later. Choose echocardiographic sign of pulmonary hypertension. TR max is present with at least two different category of echocardiographic sign. It will alter the level of pulmonary of probability of pulmonary hypertension. For example, TR velocity 2.6. If there is two category of echo sign, so it will turn to intermediate. Probability of pulmonary hypertension.
อาจารย์ครับ
ค่ะ
what do we mean by more than two echo category ครับอาจารย์
This slide show echocardiographic sign which are categorized into 3 group. And this is echocardiographic sign of pulmonary hypertension. And this is these are 3 category of echocardiographic sign, which consists of the ventricle, pulmonary artery, and inferior vena cava, and right atrium.
So you mean that it is like more than two echo signs, right, Ajahn?
If patient have ventricle is abnormal and pulmonary artery category is abnormal, that mean you should. That mean, for example, if patient have 2.6 and they have right ventricle abnormal and pulmonary artery abnormal, so pulmonary hypertension it should be intermediate level.
Okay, thank you.
This echocardiographic sign of pulmonary hypertension นะจ๊ะทุกคนนะเรากำลังจะอธิบายนะจ๊ะ ใจเย็นๆcategory A is ventricle, category B is pulmonary artery, and C is IVC and right atrium. Category of ventricle is assessment of RV and LV adaptation in response to pulmonary hypertension. The first one, the ratio of RV and LV basal diameter. This measure form the standard epical for chamber view without foreshortening. You should measure at in the assembly. The ratio more than 1 suggests RV dilatation. Okay now. Category A is also conclude flattening of interventricular septum or eccentricity index, which measure from parasonal short axis view at LV papillary muscle level. It is measured on the peak of R wave. In dias. And cis. And dias is measured on the peak of R wave, and incissory is measured at the frame with a smaller LV cavity. Eccentricity is the ratio of D2 by D1. D1 is LV diameter perpendicular to interventricular septum, and this is interventricular septum. D2 is LV diameter which parallel to interventricular septum. So LV eccentricity index more than 1.1 is abnormal. This slide show RV pressure and RV volume overload can lead to flattening in the ventricular septum. RV pressure overload cause eccentricity of interventricular septum during systole, such as in patient with isolated RV pressure overload due to primary pulmonary hypertension or pulmonary arterial hypertension. And RV volume overload cause eccentricity of interventricular septum during diastole. Such as a patient with isolated RV volume overload due to tricuspid regurgitation or right side volume overload from congenital heart disease. This may also call a D-shape นะทุกคนนะ Next category is the pulmonary artery. Pulmonary artery, this category consists of three echocardiographic sites. The first one, RVOT acceleration. RVOT acceleration time. This RVOT AT is measured by tracing, by pressing PW Doppler below the pulmonic cusp on RV side. And you have to measure from this to this million. If pulmonary artery pressure increase, AT is short. This slide show mid-systolic closure or mid-systolic notching. It's very important when you see this slide because this sign indicate high pulmonary artery pressure, or next is measurement of early PR velocity. If early PR or peak PR velocity more than 2.2 is indicate high pulmonary artery pressure. Mm. 2.2. Next is measurement of main pulmonary artery, which are measure midway between pulmonic valve and PA bifurcation. And you have to measure inner edge to inner edge at end artery. If it's more than 2.5 millimeter, is indicates abnormal. Is this abnormal? Next category is IVC and right atrium. It consists of two echocardiographic signs. The first one is Ivc diameter and Ivc collapsibility. If Ivc diameter and collapsibility less than 50, it is considered abnormal mean pulmonary artery pressure. Next, echocardiographic size right atrial pressure, which measure by tracing RA area from apical four-chamber view. We have to test RA area from the plane of bicuspid valve along the interatrial septum to another bicuspid aneurysm, so you will get RA area. If it's more than 8 centimeter square, is abnormal. Let's consider the probability of pulmonary hypertension by using echocardiographic sign of pulmonary hypertension. It may help you a little bit. Okay, first one, a patient with severe MR, severe mitral regurgitation. He has echocardiographic examination show TRV max 3.3. 3.3 จำนะจ๊ะ3.3 is in this box, in the middle box. After that, you have to if they have two category, probability of pulmonary hypertension should be in this group, right? If if there is no category of echocardiographic sign, probability of pulmonary hypertension in this patient should be in this group, right? Okay. 3.3. Patient have RV-LV ratio more than 1. Let's see, this RV and this RA, which is larger than LV and LA. So they have one category, right? And IVC dilate with hepatic vein dilatation and IVC collapsibility 20%, which less than 50. So this is abnormal. Any category 1, and this is category 3. So they have 2 category. He has 2 category, right? We can conclude that the patient have high probability of pulmonary hypertension. From left heart disease because he has severe mitral regurgitation. งงไหมอ่ะ
ไม่งงค่ะ คือต้องจำตารางให้ได้ถูกไหมคะ
งั้นไปเลยนะcase 2 a patient with ischemic heart disease. LVEF is 17 and you will see apical thrombus. Echocardiographic examination show TR max velocity 2.9, which in the middle box. So we have to by echocardiographic side. This echocardiogram show PRV max 2.5, which more than 2.2. So this category is abnormal. Pulmonary artery is abnormal. And PA pressure, PA diameter is more than 2.5. So PA category is abnormal. Next, you estimate IVC collapsibility and it is 2.9. 3.9% and IVC 2.9. This is abnormal. So IVC and RA category is abnormal. This is this LV, this RV ratio is which is the ratio between RV and LV is more than 1.0. So this ventricle category is abnormal. So you can conclude that the patient had this patient has high possibility of pulmonary hypertension. And the cause of pulmonary hypertension is ischemic heart disease. Case 3, a patient with TR max velocity 3.75. And you see D shape. Flattening of interventricular septum, which indicate RV pressure overload or RV volume overload is depend on systole or diastole. And this is RV, RA, LV, tricuspid valve, and RV basal. RV basal diameter is more than LV basal diameter. So ventricle is abnormal. Ventricle. Next is measurement of PR max velocity, which is 2.7, and pulmonary artery category is abnormal. PA diameter is abnormal, and you can. This is thrombus in pulmonary artery, which is pulmonary embolism. RA area is more than 18. Tricuspid TAPSE is 1.35, indicate RV systolic dysfunction. Patient. This is a patient with pulmonary embolism. To summarize, this patient has high probability of pulmonary hypertension. Case 4. Patient with VSD. His blood pressure is 144 and 90. TR max velocity 2.2. VSD max pressure gradient is 140. So systolic blood pressure RVSP is equal to 144 minus, and RVSP is 4, which indicate no pulmonary artery hypertension. Case 5. A patient with PDA, you see PDA4 is here, and his blood pressure is 130 over 90 millimeter of mercury, and this is PDA flow. PDA systolic pressure gradient is 89, PDA diastolic pressure gradient is 40. So RVSP is เท่าไหร่130 89 and ไปลบเองนะจ๊ะโอเคหมดแล้วมีคำถามไหมจ๊ะถูกไหมเนี่ย อ่ะมีคำถามไหมอ่ะไม่มีคิดว่าไม่มี
อาจารย์ครับมัน
ครับ
ข้อสอบจะเป็นอย่างนี้ใช่ไหมครับเหมือนเคสอะ
ใช่ค่ะ เดี๋ยวนะ เราจะกลับไปที่บล็อกนี้นะ เนี่ย อันเนี้ยสำคัญมาก ที่ทุกคนต้องรู้ แล้วก็อันเนี้ย มันจะไปด้วยกันนะและ PASP ที่สำคัญนะคะ PVR คำนวณยังไงก็ควรรู้ แล้วก็อันเนี้ยต้องแยกให้ออก mean กับ PADP ในกรณีที่บางที่เขายังใช้วิธีการประเมินแบบนี้อยู่อ่ะ ก็คือแบบประเมินว่า PAP เท่าไหร่อะไรเงี้ย ก็ต้องคำนวณได้ แล้วก็ต้องคำนวณเป็น แล้วก็ PASP สูตรที่สำคัญก็คือไซน์อันเนี้ยต้องรู้ แล้วก็ PRN อันนี้ก็ต้องรู้ PASP โดยอันเนี้ยข้อยกเว้นก็ต้องรู้อันเนี้ยต้องรู้ประมาณเนี้ยค่ะ มันมีแค่เนี้ยเราอาจจะหลอกมาก็ได้นะ หรือไม่ก็ อาจจะให้เคสมาเป็นแบบนี้แล้วก็ให้PASP มา แล้วก็บอกว่า pressure gradient ของ pulmonary stenosis เท่าไหร่ ถ้าเอาไปตอบเลยก็ไม่ถูกปะมันจะต้องเอามาลบกับ PASP ก่อน ประมาณนี้ค่ะ มีคำถามอีกไหมคะ ไม่มี งั้น เราแยกย้ายค่ะ เงียบมา
ขอก บคุณค่ะอาจารย์
ขอบคุณค่ะ
ยังอ๋องอยู่ค่ะ
ยังปรับตัวมาเรียนไม่ได้หรอ
หมาย
นี่
ถึง
ถาม
ป
หน่
รั
อบ ย
ตั
สิ
วกับเนื้อหา
เรา
ไม่ได้ค่ะ
เราไปบอกอาจารย์เปิ้ลเหรอว่าเราอยากเรียนเป็นออนไลน์มากกว่า คะ เงียบ โอเค ไปแยกย้ายค่ะ ถ้าลงตารางของนูรุนเสร็จอะค่ะ ก็ส่งให้เราด้วยนะ โอเค ไปแยกย้าย ไปน
ข
อ
อน บ
ต่
คุ
อ
ณค่ะอาจารย์
จ้ะ
ขอบคุณค่ะ
ขอบคุณค่ะ